Hi, everyone. Thanks so much for joining us. My name is Clarissa. I'm the Rural Health and Medicaid reporter here at North Carolina Health News. We are a nonprofit. All of our stories are free to read and to republish, but they're not free to produce. So if you can, please go to our website and click the red donate button and send us as much or as little as you can. We really appreciate it. It helps us run events like this and to keep paying for our reporting. Our website is northcarolinahealthnews.org/donate. So without further ado, I will introduce our guest. We were originally planned to have two guests, and also the links are in the chat. We were originally planning on having two guests, but one of our panelists woke up without a voice, so she is resting her voice, and we are joined by Doug C., who is a wealth of information.
Meeting. Well, it's.
And so Doug is a senior attorney with the Charlotte Center for Legal Advocacy. And he has worked in this area for 3 decades, working on public benefits and health law. He's led class action suits against the state and federal agencies that administer public benefits programs and a bunch of other stuff. And so he is here to walk us through how the transition is going, what people who are either providers who accept Medicaid or people who are on Medicaid, what some of the resources available are to them to navigate when they run into problems and other things. So if we will have a conversation for about 20 minutes and then we can answer some questions. So feel free to put any questions in the chat, but please stay muted so that the conversation can go on without any hitches. So I think we will get started. So Doug, can you tell us a little bit about what you've heard and seen both from people who have Medicaid and from providers who accept Medicaid? What has been going on since the managed care transition began in July? What are some of the things that have gone well, and what are some of the problems that people are still navigating?
Thanks, Clarissa. Actually, it's been 4 decades, but who's counting?
Oh, sorry.
So I have been pretty closely involved. Actually, we were involved in working with the HHS on the planning for this. And then I've been closely involved because the Charlotte Center for Legal Advocacy is one of the agencies that got the contract to be the Medicaid Ombudsman. And for those of you who don't know about the Medicaid Ombudsman, it's a really important resource for beneficiaries who are having any issues, trouble navigating this very complex new system, which of course is brand new to North Carolina and has confused a lot of families. Beneficiaries can call the Ombudsman at 877-201-3750, 8 a.m., 5 p.m., Monday through Friday. Or you could go to their website, which is ncmedicaidombudsman.org. And providers can also call the beneficiary ombudsman if they're calling on behalf of a patient or more than one patient who is having problems getting the care that they need. However, if a provider is having problems with billing or with enrollment as a provider with a plan or some other issue like that, then they should go through the Provider Ombudsman, which is a separate program run internally at the Department of Health and Human Services. So just with that background, I think that the answer to your question is that it could have been a bumpier rollout. After all, this is brand new to North Carolina, but it has been plenty bumpy. There have been a lot of problems with accessing Medicaid transportation through the prepaid health plans. There have been some issues with people being enrolled in plans without even having a choice of plans, or being switched to a different plan without requesting it, or when they do request to change plans, having those requests not necessarily processed right away, or if they are processed, there's a delay in getting the change to happen. There was something called transition of care protections, which are now gone, which were during the initial rollout to allow you to continue to see your same provider, even if they were out of network. But those were not entirely effective because the process for billing as an out of network provider was difficult for some providers to navigate. And unfortunately, we've also seen some providers just drop out of one or more plans and just decide we are not able to handle being in all these plans. It's just too many different processes, too many different forms, too many different procedures to follow. And that has narrowed the networks even more and made it even more important that people be able to change plans. And the state has been good about being liberal about letting people change plans if their provider, drops out or something like that. But it's still, again, a delay in getting that to happen. There's also been complexities around this issue of people who need to move back to Medicaid Direct. And this is largely people either like when a child goes into foster care, they're supposed to go back to Medicaid Direct. When an adult gets Medicare, they're supposed to go back to Medicaid Direct. If you start to develop significant behavioral health needs that require services that are only available through one of the LMEs, then you have to move back to Medicaid Direct. And that process has not always gone as smoothly as we would like.
Can I interrupt
some
for 1
difficulty
second?
identifying some of those people. Sorry, go ahead, Clarissa.
I was just going to say, I'm sure that we have lots of people who know what an LME is, but for people who don't, could you tell us what that acronym means?
Sure, it's a local management entities. These are the area mental health authorities that starting December 1 will become what they call the tailored plans. And these are agencies that serve certain geographic regions. They used to provide all the behavioral health services under Medicaid, and now they only provide them to the people with the most severe needs. And so the complexity of whether your needs are high enough to go out of the PHP and go in back to your LME. And if you do for now, if you go back to your LME, you go back to Medicaid Direct for all other services. Starting December 1, you'll have to get your physical health services through the LME as well. And we actually have some significant concerns about that. And we're talking closely with the department about trying to build in more protections to make sure that those folks with severe behavioral health needs are going to be able to keep their physical health providers whenever possible. So that's on the horizon. That's another area that we're gravely concerned about right now, but we're working closely with the department. They're concerned about it too, and we hope that some good protections will emerge and some strong efforts to get those providers enrolled in the right networks for those patients.
Could you say more about what your specific concerns are, or some examples of what those concerns might be?
On that Taylor plan issue,
Yeah.
or on the general? On the Taylor plan issue, the problem is that each LME is contracting with only one PHP to provide.
And what's a PHP?
physical. I'm sorry, PHP is a prepaid health plan. These are the existing 5 managed care entities that they call the standard plans, WellCare, United Healthcare, Blue Value, AMH, and CCH. So those, each LME is contracted with only one of those plans to provide physical health care. Because you can't change, and there's no ability to change plans when you're in a tailored plan. It's all based on where you live. So there's a dramatic restriction in choice of providers for the people in those situations. That's what we're worried
about. And so then I wanted to follow up on some of the things that you mentioned at the beginning. What are some of the specific issues that you've seen with transportation and with people being switched, either incorrectly switched to a managed care plan or between them? What are some of the specific issues that you've seen there, and what are ways that you've seen that you've seen people resolve those issues? What are the most effective ways that if someone's experiencing that, they can?
Let me start with the last point. The Ombudsman has been very successful and works closely with DHHS, and to their credit, DHHS has been very responsive when we escalate a case to them, we meaning the Ombudsman, in working really hard to resolve the issue and to get that problem solved. So that, again, is another reason why calling the Ombudsman is so important, because they really do have the ability to resolve the issue for the individual. The Ombudsman also is identifying systemic issues for the department, and the department is working to address those issues. One of those systemic issues is transportation. Unfortunately, the PHPs have not had enough transportation providers, and COVID has made that worse. Labor shortage has made that worse, and there have been a great many cases, too many cases at least. I'm not saying most of the rides happen exactly as they're supposed to, but I think the demand was higher than they expected, and unfortunately, we've had a number of callers who rides didn't show up, their ride was canceled at the last minute, or they were dropped off way too early or way too late, or picked up way too early or way too late, or had to drive around for 90 minutes in COVID conditions and were not safe. A number of different problems. And the department has worked really hard to address these issues, but one of the transportation brokers is about to leave North Carolina, so we're worried about what effect that's going to have. Some of the counties' transportation systems have limited how much help they're providing to the PHP, because they have to provide all the Medicaid transportation for people in Medicaid Direct. So it's been a real challenge for folks to get those problems worked out, but it is getting better. I think it's getting better. I hope it's getting better. And the demand, most people are able to access those rides when as needed. And if they're not, the Ombudsman is working hard with the state to fix that. In terms of changing plans, as I mentioned before, there's been a lot of people who need to change plans for a couple of reasons. One reason is that when you are new to Medicaid or you're new to managed care, for example, you were only getting family planning Medicaid, which only covers birth control and things like that. You're out of managed care. Now, all of a sudden, you're pregnant. So you are eligible for full Medicaid and you go into managed care. Those people are basically being auto-enrolled in a PHP without talking to the enrollment broker first. This is something we
could you tell us who the enrollment broker is and what that person's role is, or that agency?
The enrollment broker is a company hired by the state to give people choice counseling, to help them pick which of these 5 plans is best for them by who are your current providers. And who are the most important of those providers to you, and which ones are in network for this plan. And then it looks like this plan may be best for you. And they also help people switch plans when they need to. And they also help people make this request and move back to Medicaid Direct when they need to. So that is their role. But unfortunately, unless you were on full Medicaid at the time of the initial rollout, you're not being sent to the enrollment broker before you're enrolled. You are just being enrolled in a plan. And if the state doesn't have good data on you, they don't even know which of your providers are. Like if you're new to North Carolina or new to Medicaid, they don't have any data to pick the right plan for you. So those people end up often in a plan that they didn't even know they were in managed care. They're very confused about it. And they need to switch plans as soon as they can once they figure it out. They're out there in the wrong one. And sometimes those have gone smoothly, but even when they go smoothly, they're never effective until the first of the following month. So that creates a situation where once you find out, you go to the doctor and they turn you away because you're in the wrong plan. You're going to have to wait till the next month. And say for a pregnant woman, that can be very concerning when you need prenatal care. And obviously for people with disabilities or need kidney dialysis or something like that, it can be critical. So I think that it's really important that that people know that they can talk to the enrollment broker if they're new to managed care right away and get information. And they should really call as soon as they get the letter saying you're being enrolled in managed care, and say, wait a minute, it's not quite the end of the month yet. I want to try to get a different plan.
Great. Okay. So before we go on to our next question, I just wanted to remind everyone again that we are a nonprofit, and to please either go to the link in the chat box to donate, or go to our website and click the red donate button to help support events like this and the other reporting that we do on healthcare topics all across the state. So with all of these different moving parts and these different agencies, there seems to be a lot of opportunities for things to go wrong and for people to get incorrect information. And so can you give us some examples of people, either providers or beneficiaries, who've been given incorrect information and how that's impacted their ability to access care? What are some of the most common things that people are being told that is incorrect and that can impact their ability to see their provider?
There are a number of examples of that. And there are, of course, people who've worked really hard to get good information out from the department and to train the people at the PHPs and to train and to get information to providers. A lot of the confusion is at the provider level. One example is providers saying, oh, we don't take Medicaid Direct, we're with WellCare. Well, of course, if you're with WellCare, you're a Medicaid provider. And if you are a Medicaid provider, you take Medicaid Direct. That's the old Medicaid. All Medicaid providers take Medicaid Direct. You just bill through NC Tracks instead of billing through a PHP. But that's just an example of the confusion that's out there. And another example of misinformation might be if somebody at a PHP says something like, oh, we don't provide that service, when in fact the clinical coverage policies for the state say they do have to provide that service. And for at least for the first year, the plans are required to cover those clinical coverage policies. And of course, EPSDT is a critical protection even beyond the clinical coverage policies for beneficiaries under age 21, where basically if it's medically necessary, they got to cover. And so that, unfortunately, some of the staff who are providing that information are used to their private insurance plan. These companies all have their own private insurance plans in addition to their Medicaid plan. And the staff may be thinking, well, we don't cover that under our private plan, when in fact, that's not the rules they're supposed to be following. Another issue is we've seen a lot of informal denials of care without written notice explaining the reasons and without telling people that they have a right to appeal that. Anytime care is denied, they must provide a written notice, and that's not always happening. One example is a person being turned away from a pharmacy because they look on their computer and the computer says, according to your plan, according to WellCare or United Healthcare or whatever, you have third-party coverage, you have private insurance. Well, in fact, that beneficiary hasn't had that private insurance in years, but the system did not get updated, and it still shows that this person has this private insurance, and they're just turned away without any written notice at all. And so that is, and of course, when they call the ombudsman, we're able to get it fixed. We've seen a number of these data glitches where, for example, DSS fails to put into NCFAST. The county DSS fails to put into their computer system, which is called NCFAST, a change in the person's status. Like this person is now in CAP-DA, which is a waiver program for people to stay out of nursing homes. And therefore, they should be put back in Medicaid Direct. Well, if the DSS doesn't put that into NCFAST, they're going to stay in a PHP. They're not going to get moved back to Medicaid Direct. Or if DSS doesn't put in, this person now has Medicare because they've turned 65, then they're not going to move back to Medicaid Direct like they should. Another example, so that those are ways the data can be wrong, but sometimes even when DSS does put it in, it doesn't show up in the PHP system. Mm-hmm. So DSS knows this person has full Medicaid. The Medicaid Contact Center, which is another good resource, knows that they have full Medicaid, but the plan system is out of date and doesn't show them and says, sorry, you don't have coverage. So those kinds of data glitches are causing a number of problems.
Mm-hmm. Mm-hmm. And it sounds like I want to get to some of the questions in our last couple of minutes, but I also want to leave people with a step of what to do if they're experiencing one of these problems. And so it sounds like your recommendation is that people call the ombudsman.
Absolutely, call the ombudsman, or if it's a billing issue, call the provider ombudsman or email them. And I think that is definitely the best piece or the first stop for people, unless, of course, what you're trying to do is just find out what plan you're in or change plans, then call the enrollment broker.
Great. Okay. So I'm not sure if you'll know this, but maybe you can point us in the right direction. Do we know what percentage of Medicaid mental health providers are independent practitioners, and what percentage of mental health treatment is provided by practitioners with associate licenses? Do you know who might keep that data?
I think the state may have that data, but I certainly don't know.
Okay. And so is the enrollment broker responsible for enrollment of 65 and old into family planning? I'm not sure exactly what that is, but who is the enrollment broker? Can anyone call the enrollment broker? Can they help anyone who's on Medicaid?
The enrollment broker is to help people who are supposed to be in a PHP, a plan, one of these managed care plans, or they want to get out of a managed care plan. The enrollment broker has nothing to do with family planning, which
Okay.
is an eligibility category for people who are not eligible for full Medicaid. It's not for people over 65. It's basically for younger adults who don't have children or they're over income for Medicaid, full Medicaid, something like that, to at least give them annual screenings for reproductive health. But those people are in Medicaid Direct, so they don't have anything to do with the enrollment broker. Over 65, most people have Medicare, so they are also in Medicaid Direct. And the state is requesting to make that permanent for the life of the demonstration, which I think is great news, that these people will get to stay with a broader choice of providers, because they do have complex healthcare needs, and some of them are already in managed care with Medicare. So the complexity of two managed care plans and two competing networks would really be challenging for them. But I think that I hope that answers that question.
Mm-hmm. And so I think our last one is going to be, one of the people in the audience is having an issue. Is having issues trying to help their families navigate problems. Can the care manager from an organization call the ombudsman on behalf of the client and family to help?
Absolutely, as long as the person is either on the phone or in some way giving permission for us to talk to that person, or you have a release form or something to show that you've got authority to speak on that person's behalf. We can open a case in their name. But if you don't have that, you just want to talk about general issues your patients are having, we can talk to you and just put the case in your name and still report on what you're hearing to DHHS and give you information and advice.
Great. So we are at 9 o'clock. So if anyone needs to leave at 9 o'clock on the dot, just wanted to let everyone know. So again, we are a nonprofit. So please donate to help keep supporting our work. We've done coverage of this transition as it's played out. Our most recent reporting found that the ombudsman fielded like 10,000 questions in these first 7 months, and including complaints about denial of payment for services, denial of services, access to care issues. And so if you have anything, if you are a provider, if you are a person on Medicaid, always feel free to reach out to us too, so we can help look into, what's going on and if it's a systematic issue that other people are having. And every donation really makes a difference. So again, there is the link in the chat box if you can donate today. And I just wanted to ask Doug, is there anything else that you want to add or that you want to leave us with before people move into their days?
I just think people need to stay engaged. There are more changes coming. I think that people who are dealing with patients with complex needs, I think the ombudsman really wants to hear from you. Oh, also, there is a webinar if you want to learn more. Charlotte Center for Legal Advocacy and the National Health Law Program and Disability Rights are having a webinar on March 22nd. So a 90-minute webinar about what's going on and what's coming. And if you email me at doug.s@charlottelegaladvocacy.org, I'll be happy to make sure you get an invite. And it's free.
Great. Well, thank you so much. Thank you everyone for attending, and have a good day.
Thanks.